Hello, Dr. Malone.
Hello, Rachel.
So good to see you.
It's good to see you too. Happy Menopause Awareness Month.
Happy Menopause Awareness Month. We are going to get into it. I wanted to speak with you. Here's what happened. I thought about the first time I think you and I kind of had time to hang out together. And you shared with me that when you had your practice, you had this sort of fluid, easy conversation with women all the time about perimenopause, menopause, this season of life, and what was available to them. And at that time, it was before the revisiting of WHI.
Mm-hmm.
And I remember listening to you and sort of being gobsmacked by this picture that you painted that seemed really, again, just so reasonable in terms of women's health care. And where we were in that moment was sort of fighting to enter into this space
Mm-hmm.
and say, look, this is available. It's always been available, and it's really helpful. I remember you telling me something. You had a patient who was an older woman. I want to say she was in her late 70s, early 80s, and she sort of secretly said, don't take this away from me. Don't take away my
Mm-hmm.
script. So I wanted to ask you about when you look back on this earlier period in your career, what were women being told about menopause prior to WHI? And then what happened around the WHI?
Right. When I started practice in 1992, so this is a full 10 years before the Women's Health Initiative came out. And bear in mind, hormone therapy had been around since 1942.
Yeah.
So when I started, we had 50 years of experience prescribing hormones to women who were symptomatic. And and I say we as a profession, we learned some things along the way. We said, okay, don't give estrogen by itself. You need to give progestin. And we adjusted along the way. And women were doing quite well and were quite happy on their hormones. And not only were we using it to treat symptoms, we had a lot of observational data that said, that women who took hormone therapy actually had a decreased risk in heart disease. And
Mm.
so that was really the conversation that we were having when I started. Yes, it treats symptoms. We know that. We've known it since 1942, but we've got this accumulated observational data that says, oh, well, look at this. Women who took hormones had, half the risk of heart disease as women who didn't. And that was really the message that we were giving women then. And I, prescribed like that for 10 years
Right.
before the Women's Health Initiative came out. So imagine the shock it was to me and to everyone else that I had been singing the praises of hormone therapy for the past 10 years. It was shocking, and it really sort of flew in the face of all the clinical data that we had up to that point.
All right. So I know you've shared this before, but tell us a little about that moment
Oh,
when yeah, I know when the news came out, the news as it was given, as it was reported, what happened with you, your patients, and everything?
right. Well, you know how people all say they can remember what they were doing on days, these
Yes.
pivotal historic days, like
Yes.
where were you when JFK was shot and when the World Trade Center came down? It was that level of a
Wow.
seismic event in our world of gynecology. So when that study came out in 2002, now bear in mind, there's a big press conference they held at
Right.
the, here, and I'm like, who has a press conference to announce a study result? Nobody,
Right.
right?
Right.
But it was such a big deal. And they said, headline was hormone therapy doesn't decrease the risk of heart disease. That's bad enough. But not only that, but it increases the risk of breast cancer. And when you put all of the side effects and roll them into a big ball together, that the risks outweighed the benefits from hormone therapy.
Mm-hmm.
That was 180 degrees from what we had been saying up to
For
that point.
years. Yeah.
Um, and the problem was, Rachel, is not just that they said it, it was that they gave the press conference, New York Times, Washington Post, every major newspaper covered it, as well as all the morning TV shows. And it was a full 10 days before
Wow.
we were able to get the article to read it.
So you clinicians had not even seen the data.
No.
You hadn't seen anything.
No, not only
Wow.
that, but I have heard from, from Dr. Blooming, Avram Blooming, who said that at the time, not only did the doctors who prescribed not new, but the doctors who were actually involved in the study had no idea that the study was closing. You remember, there were like 40,000 women enrolled in 40
Wow.
different centers around the country. They had no idea that the study was being stopped. So you can imagine what happens in 10 days. That vacuum just got filled with
Yes.
negative information about HRT. Then you finally get the article a week and a half later. And then I read it and I said, wait a minute. It didn't say that. It was, and that's where I think that the misinterpretation came in of the data. The women who were enrolled in the study were too old. They weren't really reflective of who we prescribed for. The average woman was 63. They were more than 12 years after menopause. And you could be anywhere from 50 to 79 years old to be in the study. And and I say this a lot because it doesn't take a rocket scientist to figure out that if you're trying to do a study to say whether or not it prevents heart disease, perhaps you shouldn't enroll 79-year-olds in a
Right.
study.
And
You
tell
know,
us why. Remind us why.
because of the fact that if you're going to do a prevention, taking the timing of when you start the hormone therapy
Right.
matters. So you can't give someone hormones after they already have established heart disease. And the overwhelming majority of the women in the study who were over 60, and then you had all these women who were 70 to 79, and whatever sort of negative effects that you saw, they were concentrated in the much older women.
Yeah.
And
I'm sorry. Go ahead.
no, and I was going to say, and that's not typically how we prescribed hormones. And the women didn't have symptoms either.
Right.
So,
Right.
if you're going to say it doesn't help with symptoms, well, how about this? They didn't have any symptoms,
Well, yes, and the reason I didn't mean to put you on the spot in asking why, I just remember as a layperson, I'm not a clinician, but I remember hearing you talk about that very point and talk about even breast cancer, that the
Right,
older one lives, the more the
right,
likelihood that she will develop breast cancer. And
exactly.
so the skew of the study was so great. And I remember just thinking, this is incredibly important to know, and none of us knew it.
Right. And here's a point about the breast cancer that also did not get adequately explained was that when someone says there's a 26% increase in the risk of breast cancer, well, that sounds horrible, right?
Yeah, yeah.
Who wants a 26% increase in any cancer, right?
Yeah.
But when you look at it in terms of not just the percentage increase, but the actual absolute numbers of the women who had breast cancer, in the women who took estrogen and progestin, it went from the women who did not take hormones, the incidence of breast cancer is 30 per 10,000 women per year will be diagnosed with breast cancer just for being a woman and having breasts.
Right,
Okay,
right.
that's the baseline. For women who took estrogen and progestin, it went from 30 per 10,000 per year being diagnosed to 38 per 10,000 per year. So an additional 8 per 10,000, or less than 1 in 1,000 additional cases of breast cancer were diagnosed in the estrogen and progestin group. Now, if I said you have a less than 1 in 1,000 chance of being diagnosed with breast cancer on HRT, that sounds a whole lot less scary than a 26%
Sure,
increase.
sure.
But here's the other part of that. When they looked at the mortality, which was even of those additional women who were diagnosed while on estrogen progestin, no increase in the risk of dying from
Incredible.
from
Incredible.
HRT. So whether you took it or you didn't take it, your prognosis was exactly the same. And that even took more of the sting out of the breast cancer
Right,
conversation because, again, less than 1 in 1,000. And we won't have time to get in that, but even that is debatable as to
right.
how they interpreted that data. It may,
Yes.
there may be other reasons why. And the part of the study that did not get stopped, the study was supposed to go for 8 years. The estrogen progestin group got stopped at 5 years. but they let the other group go on for another 2 years. And that was the group for women who took estrogen only because they had a hysterectomy.
Hmm.
That was allowed to go for another 2 years. And guess what they found about breast cancer? No increase in the
No
risk of breast cancer.
increase.
No increase.
Incredible.
And now we have 20 years of look back data. And that 26% increase has gotten smaller and smaller, the differences between the two. And in the estrogen only group, which is, I really want to say this is important, the women now looking back 20 years, the women who took estrogen had a 23% decrease in the risk of breast cancer. And more importantly, they had a 40% decrease in the risk of dying from breast cancer. So in the estrogen only group, it was more protective than it was even an increase.
That's incredible.
But was there no press conference about that, by the way?
No, no.
No,
So
no
so
press
that
conference.
that leads me to the my next question, I guess, but you're making me think so many different things. You talked about this vacuum that was
Hmm.
now big and wide and ready to be filled with all kinds of anything,
Right.
trash. You're practicing your medicine. You have women coming in and out of your office. Some are upset
Oh,
about what,
very,
right? What have you been giving me? I can
very.
only imagine. And then
Yes.
there are others who are saying, I am feeling great. Please don't take this away from me.
Right.
And in the 20 years since, as you've seen, as you've revisited the study, you've looked back, there's more data that's coming out. How do you sort of push back against the damage that was done?
Well, Rachel, even in real time, and that's why I was saying how seismic an event it was when that study, phones, ringing off the hook, patients are coming in going, oh, Dr. Malone, I can't believe you gave me this stuff and it's going to give me breast cancer. That was the narrative we were trying to fight against.
Sure.
When I finally got the study, read it, and I went, oh, it didn't say that. Women voluntarily stopped taking their hormones. I
Yeah.
never took anyone off hormones on the basis of that study. That's the point. Because I tried to explain to them, we said, oh, the women were much older, they weren't symptomatic, they were too far away from the time of menopause. Oh, and even if you believe that result, it really wasn't as scary as you would think it. I couldn't convince, even explaining in real time,
Right.
I couldn't convince women to continue with their hormones. Now, what happened, most of the women stopped them like overnight. But then there were a few that would come back and say, you know what? I'm kind of miserable. And I'd say, well, you know what? It's okay. You get
Yeah.
to choose to take hormones. But what was the most pernicious effect was not the women who had been on, realized what their benefits were, came off, and then went back on again. Those weren't difficult to really, convince about it.
Right.
It was the women who didn't take for those 20 plus years after that study came out. I would see women who were miserable, suffering, hot flashes, all of the symptoms that we talk about. And I would say, you can take HRT. And they would go, no, I can't. I can't take hormones. My mother had breast cancer. I can't. And I watched these women suffer
Yeah. Yeah.
needlessly for years. And then some would eventually come around, but it never came back the way that it was before that study. And that's the unfortunate thing, that you've got, 20 plus years of women who suffered, who were too afraid to take hormones, even when you had someone that tried to explain it to you. That's the problem.
Yeah, you're actually making me think of my own story. I had a mother who was given hormones, was recommended to get off of them, suffered, developed osteoporosis and all an
Hmm.
assortment of
Hmm.
things. And I was suffering with symptoms and never considered hormones, even though I was having conversations with
Hmm.
physicians who
Hmm.
knew the science, you
Hmm.
among them, who actually was the one who explained the cardiovascular
Hmm.
benefits that we
Hmm.
understood to be
Hmm.
true. And it wasn't until I heard that I started to think about the risk benefit.
Mm-hmm.
cardiovascular disease. My father had recently
Mm-hmm.
died of that. I was hot flashing so severely that it was not reasonable to continue on, but I was willing to muscle through because the
Mm-hmm.
messaging was so
Mm-hmm.
successful
Mm-hmm.
around breast cancer that I didn't even think about it. I just thought, oh no, it causes breast cancer. It
Right.
was like embedded in me, and so I
Right.
wasn't going to try it. So
Right.
I look at you now, all of the physicians that we get to interface with, and I think about women like myself who finally, for one reason or another, said, this is enough.
Mm-hmm. Mm-hmm.
I'm gonna do this thing.
Mm-hmm.
And I think, how can we collectively continue to push against that fear that's not based on a truth?
Well, there are two things, because there is not only the narrative that has gotten out into the general population, which associates estrogen and breast cancer, but there is also the lack of information amongst that entire generation of physicians,
Yes.
who were
Yes.
trained post WHI, and they think the same thing that patients think, because they're like, oh, well, they were taught that there's an increased risk of breast cancer. And so unfortunately, even when there were cases where you're able to say, okay, I get it, risk benefit, no medication is without risk. I'm more at risk for heart disease than I am for breast cancer or anything else, or I'm just miserable. I don't have to be at risk for either one of them.
Hmm.
And I choose to do hormones. Even with that, women have difficulty finding a doctor. Remember those
Yes.
20 years of
Yes.
doctors who think the same thing? They have difficulty finding doctors who will prescribe for them. And that is why you and I do what we do at Alloy, because it is a matter of, it doesn't do you any good to have all this great information and to be able to counter it if you can't find a prescribing
Yes.
physician. So what we do, Rachel, is that we make sure that women have education, number one, but you also have access, because I think it is vitally important that we understand that women are capable of understanding things. We are able to say, to weigh the risks, the benefits, and to say what the Menopause Society has said for women who take hormone therapy between if you start before age 60 or within 10 years of menopause, the benefits outweigh the risks.
Right.
And let's say that again. So that's not my opinion. That's not your opinion. That is the opinion, the consensus opinion of multiple endocrine societies, the American College of Obstetricians and Gynecologists. Everyone is like, the benefits outweigh the risks. And let's not deny the fact that women's quality of life
Yeah.
matters. I mean, if you say, now there's a little bit of controversy, and that'll be a subject for another IG Live. But now the controversy is, does HRT prevent cardiovascular disease or doesn't it? And then we argue about, well, the guidelines say
Right.
you can't say it. But I'm
Right.
like, well, look, let me make this case, because I think as a physician, we get to look at data, and we very rarely have perfect data.
Yes.
And we very rarely have, information from a randomized placebo, control study about having to make these kinds of decisions. But let me make my case for the prevention part of it. If taking hormone therapy decreases hot flashes and night sweats, which we know are independent risk factors for heart disease.
Yes.
If we know that it improves the quality of sleep, also an independent risk factor for developing heart disease. If it decreases your cholesterol and improves your cholesterol profile, also a risk
Also,
factor for
yes.
cardiovascular disease. If it decreases the belly fat or that visceral fat that develops after menopause, also a risk. It strains credulity to
Yes.
me to say that we have a medication that decreases all those risk factors for heart disease, but it doesn't prevent heart
Right.
disease. That
Right.
makes no sense to me. And I so that's why I said that's an argument not worth having.
Yeah.
because I think that that's one that you're going to have to say, well, you know what? I've looked at the data. This is my interpretation. You can have your own interpretation if you don't want to say it prevents it, but all indicators are in line with the fact that it
Yeah.
does.
Thank you for that. That's so important, so brilliant, so reasonable. Um, I know we don't have that much time with you, Dr.
Hmm.
Malone, so I'm skipping a whole bunch of questions to ask you. Once a woman is in menopause, when
Hmm.
she's moved through that transition,
Hmm.
what becomes most important for her health and well-being?
You know what? Her quality of life. Let's not, we have a lot of medications that are out there. And let's say, and I always use this example of Viagra. you know
Mm,
let's just take that's a big, pill to swallow, to say that, all right, forget all those great health benefits, and there are:
right.
preventing the genital urinary syndrome of menopause, decreasing your cardiovascular risk factors, decreasing the risk of osteoporosis, hair, skin, sexual function. Okay, putting those to the
Putting
side,
all of those aside.
all of that to the side.
Yeah.
What about your quality of life? What about feeling better? What about sleeping through the night? What about not having serious brain fog or irritability, or all of those things that really help you manage and help you feel like yourself throughout this? Why would even if you didn't have those other things, why, improving your sexual function, why don't women get to choose to feel better? I don't understand that. Men do.
Yes.
We take Viagra has a list of side effects that are immediate, and some others that are long term, that are quite scary. And you
Yeah.
know what men get to say? Men get to say, "What? Let's see, I might go blind, I
Right.
might have a heart attack, I might pass out."
Right.
And they get to say, "Oh, but I get an erection? Oh, yes, I'll
Yes.
take it.
I'll take that
I'm
pill.
willing to take those risks
Yeah.
because this is important to me for my quality of life."
Yeah.
And we have medication that we have a long history with, whom we know about the health benefits of taking. And yet, even if you don't have a risk for any of those things, why can't I take it for quality work? Am I not, intelligent enough to be able to make a decision
Yes.
for me?
Ultimately, can I make my decision for me?
Yes.
Please,
Yeah.
can you inform me so I can make the best decision for myself by myself? Thank you for that. So we're definitely in this moment. Um, there's this menopause awakening. I think we're like at the getting towards the end of a very long path. Not the end, but like we've come a long way is what
We
I
have.
meant to say.
We have.
What excites you most about where the conversation is going?
And Rachel, I've been doing this for a very long time, but out here in the public sphere talking about menopause, not just one on one in my office, but to be out here, what encourages me the most is the appetite for this conversation.
Mm,
So many women want to hear it. We are, I think, collectively destigmatizing menopause.
yes.
We are saying it out loud. We are realizing that, yes, I do deserve to feel better.
Mhm.
And all of these things about our bodily function as women that we have been taught to be ashamed of, we're done with that.
Done with that.
We're done. I
Yeah.
mean, and you and I know, when we go in these rooms and it'll be 300 women, and we hear someone will stand up and they will ask a question that I promise you no one would have said out loud. They wouldn't have
Yeah.
even whispered it
Yeah. Yeah.
10 years ago.
Yeah.
And they can go up there and step up to that mic, no shame,
Yeah.
no embarrassment, and ask the question that they want to get answered.
It's
That
wonderful.
is what's most encouraging to me, that we are leaving that, some of that taboo about
Yes.
menopause, leaving it
Yes.
behind. Yay. So yay for that.
Yay. So to that, one new way I know that you are continuing to amplify this conversation, in addition to your book, Grown Women Talk, and if anybody has not gotten themselves a copy, please do. Really, please get this book. It's a wonderful, wonderful book that Dr. Malone wrote. Um, you've got a new podcast,
I do. I
The
do.
Second
You,
Opinion.
just what the universe needs, another, right?
We do need it. We need to hear more from you. We need to hear more from
Well,
you. So congratulations, and could you tell us about it?
yes. Well, thank you. Yes, my podcast is called The Second Opinion with Dr. Sharon. It's where you can listen to it wherever you get your podcasts, YouTube, Spotify, Apple. But it is really to address all things women's health.
Mm.
And, I want to not just talk about menopause, I do a lot of that, but it's all things. So we're going to talk about fibroids, we talk about PCOS, we talk about Alzheimer's. But I want you to know that in an environment where you're bombarded, we went from no information to now we've got too much information.
Hmm.
It's coming at you from all directions. And people realize that women need solutions. And in an environment where you're only going to get 5 to 7 minutes of FaceTime with a doctor, you're not going to get all of these topics explored in depth. And if you're trying to research on the internet, it's hard because you don't know
Yeah.
who to believe and who not to believe. So that's really the premise of the second opinion. I'm going to tell real women's stories. So I'm going to talk to real women about their health issues, and we're going to do deep dives and things that I know about. I'm going to talk about. But you know what? There are things that I don't know.
Hmm.
I'm not a
I don't believe
cardiologist.
it.
I'm not an endocrinologist. So that's why I will have vetted experts that I will have, and we will be able to, because we're not constrained by 5 to 7 minutes, we can do deep dives and talk about the things that you want to hear about, all things that affect women's health, and particularly in midlife, because so many of them haven't been adequately addressed.
It
And that is the premise and the purpose of the second opinion with Dr. Sharon. I have 2 episodes that came out this week, and there will be a new episode every week. You can also go to my website, drsharonmalone.com. That's drsharonmalone.com. And put in, go to the second opinion and put in your request. Tell me what you want to hear about.
I love that.
Because yeah, I don't need to do a podcast just to hear me talk to me, you know.
I love to hear you talk, and you're making me think that your podcast is really going to kind of run in parallel to your book, which was
Yeah,
also
yeah,
educating women specifically, or in large part, women in midlife about what to
right,
expect, what to be thinking about, what to consider, what to
right,
go armed into their next 5 to 7
right,
minute doctor's appointment with. So I
right,
love
right.
all of that.
Right. And I think that the thing that's most important, Rachel, that all of our listeners understand is that why we do what we do here at Alloy. And I think I can't think of an environment that is more important because, women are losing access by the
Yes.
minute. And we have a commitment at Alloy to providing, science based. This is not, like just stuff that we just pull out of the air.
Yep.
Science based solutions to perimenopause and menopause, and it's delivered by doctors.
Yeah.
We
Yeah.
have doctors on the end, and we have a commitment to making this accessible. We're in all 50 states and the District of Columbia, and affordable. And
Yeah.
let me just say, for most of the solutions that we have on Alloy, it's less than what most people spend on a hair or nail appointment, way less than a hair appointment, but
Yeah.
less than a nail appointment, or what they're spending already trying to solve a solution with supplements that really don't work.
I can attest to this personally and tell you that when I was first a customer of Alloy, before I came to work with Alloy, I did not have health insurance. And cost of anything was
Hmm.
incredibly difficult for me. Accessing a doctor's appointment was not
Hmm.
something I could do, but I was
Hmm.
struggling and I was suffering. And when I did the numbers,
Hmm.
I realized this is basically a copay, and
Right.
I can manage this and I can
Right.
feel better. And night
Right.
one, my stuff came, my supplements were pushed way to the side, way
Mhm.
to the back of the cabinet before they were disposed of, not all, but most. And I felt better. I got a good night's sleep. My heart palpitations resolved. Within 2 days, my night sweats and hot flashes resolved. Within a week, 99% of my symptoms resolved. And I had a back and forth with a physician who was available to me anytime I had a question, whether it was related to my prescription or something else
Mhm.
related to what I was struggling with. So, with that, I just want to quickly encourage everyone again, as I said before you hopped on, Dr. Malone, in honor of Menopause Awareness Month. The code MENO25 is available for anyone and everyone to use over on myalloy.com. Dr. Malone, I can't think of a better voice to guide this conversation or any other about anything. I mean, whether it's, cooking in the kitchen, still waiting for a pound cake, by the way, or or anything midlife, health, menopause related. It is just a pleasure. Might I also add, you look especially beautiful today. I'm a little distracted by just how lovely you are. So with
It's
that,
all for you, Rachel.
it's
You should have seen me. You should have seen me an hour ago. Okay.
I don't believe it. Everyone, check out The Second Opinion with Dr. Sharon. Do get the book, Grown Woman Talk, and look for us always on Alloy. We're here and we're here for you. Thank you for this conversation, Dr. Malone.
Always a pleasure, Rachel.
Be well. Bye, everybody. Thank you.